Good afternoon, everyone, and welcome to today's webinar on vaping, clinical manifestations, risk-benefit equations, and policy implications. My name is Karen Labello. I'm Director of Education for the New York Chapter ACP. Our speakers today are Dr. Samir Kanijo and Dr. Ankita Sagar from Donald and Barbara Zucker School of Medicine at Hofstra Northwell. Dr. Samir is Assistant Professor of Medicine, a pulmonologist at North Shore University Hospital, Division of Pulmonary Critical Care and Sleep Medicine. And Dr. Sagar is an internal medicine physician and Assistant Professor at Hofstra Northwell School of Medicine. Before we begin, I want to review a couple guidelines. All participants will be on mute. If you have a question, please type it in the dialog box on the right, and Dr. Kanijo and Dr. Sagar will answer all questions at the end. If we run over the allotted time, we will send the answers to your questions through email. We do have scheduled for 1.5 hours, 12 to 1:30. Following the webinar, you'll receive an email with the handouts and a link to the recorded version of the presentation. This webinar is accredited for 1 CME credit hour and 1 MOC point for members who take the survey. To claim CME credit, you'll be sent a survey through email within a couple of days from Northwell, and you'll have 3 weeks to take the survey. And we will have a recorded version of today's webinar posted on the Early Career Physicians page of the New York Chapter ACP website. I would now like to introduce Dr. Kanijo for the webinar.
Hi, thank you, Karen. So thank you everyone for attending. Dr. Sagar and myself, we're just going to talk a little bit about vaping-associated pulmonary injury, things you've seen in the news a lot recently, as well as some of the policy implications, and what we as physicians can do to help not only the community, but our patients and everyone at large. So really, it starts with a definition. The CDC has retermed this to EVALI, or e-cigarette or vaping product use associated lung injury. Not the sexiest term, but gets the idea across of what we're looking at and what we're doing. We have no disclosures to report, and this again is just our objective. We want to recognize the background and terminology of vaping, recognize the clinical and radiographic manifestations, interpret and apply the CDC guidelines and recommendations, assess the risk benefits of using e-cigarettes for smoking cessation, and identify current and next steps in physician advocacy on vaping and regulation. So just a brief overview of what we're looking at, what we're talking about. And we have to all take a step back and think about why we're here. We're here for our patients. This young man in the picture is Gregory Rodriguez. He was a young man that came to us and ultimately turned out to have vaping-associated lung injury. He was nice enough to share his story with the New York Times on October 15th, so I'm not going to give away all his details. But if you're interested, you could find out what his story was, what he did, but also see some of the ramifications. He was our first patient that actually ended up not only needing to be intubated, but having to go on ECMO for oxygenation support because of how bad, how devastating his lung injury was. Fortunately, he got better. He's able to tell his story. What we know so far, as of December 3rd, the CDC has been releasing data weekly, and actually as of the 3rd of December, they started saying we're only going to release data on patients that are hospitalized. There have been 2,200 cases of lung injury in all 50 states and 2 territories. Alaska was the last state to have a lung injury case. There have been 48 confirmed deaths, and on CDC data, looking at almost 1,400 of these patients, 70% are male and 79% are under 35. That's a jarring statistic, especially to me as a pulmonary physician, to all of you out there as internal medicine doctors. We're used to seeing people get sick as they get older, but we're not so used to seeing young people come to us with respiratory failure and sometimes very profound respiratory failure. So something that we really need to keep on our minds and watch. This was the legend from December 3rd, looking at all the states that have been affected. Obviously you see Texas, California, Illinois sort of being among the most affected. New York has in between 100 and 150 cases reported. But again, I think all these numbers are somewhat underrepresented. One, there's lag time, but 2, also all the hospitals haven't been reporting all of their cases, just as we've started to see more and more of these. The CDC also released data on what people were using. So out of 1,782 patients, 80% documented using some sort of THC-containing product, 35% only using THC. 54% were using some sort of nicotine-containing product, but 13% of them said they only use nicotine. Again, 1% said they only use CBD, and 5% stated that they use no nicotine, THC, or CBD. And so whether that's lack of knowledge or understanding or fearing repercussions of telling providers that they're using substances, We don't know. But if we take this data to be true, that's about 19% of patients that say they're not using, or 18% of patients that say they're using only nicotine or no substance at all in their vape devices. And this becomes important as we try and figure out what is the thing that's causing their lung injury. So one of the things that's been on the back burner of one of people's minds is that this lung injury is coming from tainted THC-containing products. And so, the CDC was able to get data and information on what products people were using, and they found over 150 different products and brands reported by patients. These are some names. If you talk to your patients about these things, these names may be familiar. If not, they may not mean anything to you. But Dank Vapes in the Northeast and the South has been the brand that seems to be most related to lung injury. TKO and Smart Cart in the West Coast, and Rove in the Midwest. Ironically, our last couple patients have actually been using Rove and Smart Cart. So again, you see all of these everywhere, and it sort of harkens back to the idea that our social history becomes important. We have to know what our patients are doing. We have to understand what they're using, whether they're making it themselves, whether they're modifying it, and maybe this needs to become an integral part of what we do as we care for our patients. Looking at presenting symptoms, right? How do these people present? Oftentimes they come to an urgent care center or a primary care center before they end up in the hospital, and the symptoms are very nonspecific. Looking at the first paper that documented this in the New England Journal of Medicine, which was from Layden et al., and looking at CDC data that came out later, looking at 390 patients, the symptoms are very similar. So from the New England Journal, there were 98% of patients had respiratory symptoms, 81% had GI symptoms, and 100% had constitutional symptoms. So, these people are coming in with cough, shortness of breath. Sometimes they're coming in with abdominal pain, nausea, vomiting, or maybe it's just fatigue, malaise, and headache. So the symptoms can be very nonspecific, and we're not 100% sure why, but these patients are getting very sick, and they're getting sick in front of us. And so again, things that should clue us in on what to be vigilant for, what to think, and where we should start asking our patients for these symptoms. There have been some algorithms that have been suggested in terms of how we manage these patients. One such algorithm is looking at what's either a highly suggestive case or something that's either confirmed or probable. We'll get into definitions of those from the CDC in a little while. Do our non-invasive diagnostic testing, so that's all blood cultures, sputum cultures, HIV testing. In our cohort of patients, we've started looking at ESRs and CRPs because there seems to be a very high inflammatory cascade. We've noticed abnormalities in procalcitonin and INR, so not really sure what they mean. And recently, we've actually started to notice some of their T-cell subsets are low. And again, why this is happening, we don't know. I think, unfortunately, a lot of this is evolving in front of us, and there's still a lot more to be learned. But some of the things that clue us in as to whether or not EVALI is actually a diagnosis. Empiric therapy, again, often begins with antibiotics, oxygen, and then steroid therapy. I think as we've come through this epidemic is the word I'll use, is we found that people respond to steroids. Why they're responding to steroids, we don't know. Maybe it's because everyone gets better. Maybe because it's decreasing this inflammatory cascade. Whatever the reason, people seem to be doing better with steroids. Again, there's no real consensus on dosing, duration, timing, but steroids seem to be of benefit. It's then continued treatment, so trying to get people off antibiotics when we identify that there's no infection, coming down on their steroids and weaning down on their oxygen. And fortunately, most people are actually able to leave the hospital without supplemental oxygen, suggesting this is a very transient process, something that gets better pretty quickly. And then if they don't have any improvement, go down the lines of more invasive measures, whether that means bronchoscopy with biopsy, whether that means intubation, ECMO, or otherwise, and really trying to see, again, as a pulmonologist, as a physician in the hospital, we worry that we won't want to miss something. And so whether or not bronchoscopy should be done on all patients or not is still a little bit of a controversy. However, the CDC doesn't recommend this or doesn't require this as part of our diagnostic algorithm. The pathology that we've been seeing, you see here, so things like lipoid pneumonia, organizing pneumonia, acute eosinophilic pneumonia, are all pathologic and bronchoscopic findings that we notice. However, if you think, again, if we don't require invasive testing, so if we don't require bronchoscopy, we don't require lung biopsy, we're not really going to know what these patients are presenting with. We're sort of treating them on this presumptive diagnosis of EVALI. Where this becomes important are diagnoses like organizing pneumonia and acute eosinophilic pneumonia are both treated with steroids. Diagnoses like lipoid pneumonia whether it's an exogenous or an endogenous lipoid pneumonia, it sort of goes down a rabbit hole that we don't want to go through today, but has to do with removing the irritant. So when lipoid pneumonia was first diagnosed years ago, it was when people were using castor oil for constipation and then aspirating on it, and they were finding droplets of fat or lipid-laden macrophages within the lungs. These days, whether it's the macrophage attacking the bad cells in the lung and causing these lipid-laden macrophages, or it has to do with the oil that's within the substance that people are vaping, we don't know. But again, presumptively, inhaling oils and alcohols is probably not the best thing, and that's probably what's depositing in the lungs. The other thing to recognize is all of these diagnoses are really on a spectrum of lung injury, and that's what we're seeing. We're seeing an acute injury to the lung caused by some pathogen, and we'll talk about possible etiologies in a little while, but we don't know yet. Just a little bit of background to take a step back, sort of what is vaping, what are we talking about, what do these things look like, who's doing it, and this gentleman is Han Lick. He's a Chinese pharmacist, and he's really credited with developing the first e-cigarette as we know it. And the story goes, his father died of lung cancer, and he was looking for a way to create a smokeless cigarette or a non-combustible cigarette. And ultimately, he did in the early 2000s. This product came to the market in the U.S., I think, in 2006 or 2007. So although it feels like when you see these around that they've been around for a long time, it's really only about a decade of information that we have here in the United States. And since they've come to market, there's been an explosion of their popularity. This is a multi-billion-dollar industry. That's billion with a B, and really something that the tobacco companies and the vaping companies have been very savvy with their marketing. I think Dr. Sagar will talk about this a little bit later, but we got into a point where as a community, our smoking rates had decreased, especially among our kids, to near negligible rates, to the points where as organizations, we didn't feel the need for as aggressive tobacco task forces and things like that. But now with the introduction of e-cigarettes, there's been quite a rapid rise in e-cigarette use, to the point where one survey earlier this year in the New England Journal of Medicine documented that about 25% of high school seniors have used some e-cigarette or vaping products within the last 30 days. Again, that's a ginormous number of patients and people, and that's scary. So the basics about vaping, these include devices, liquids, flavors, refill pods, cartridges. These are devices that heat liquids to produce an aerosol that's inhaled. And then vaping of this aerosol is obviously going to contain harmful substances that we don't really know about. This is sort of diagrammatically what an e-cigarette looks like. It has a mouthpiece, obviously, where you inhale from. There's an atomizer or a tube where the liquid goes, a battery and coils. And so the coils are often made of metals. The battery heats these coils, allowing the liquid that's in the atomizer to heat up, and then people inhale it and exhale. Again, another diagram. So these come in many generations. So the first generations were called cigarettes because, again, they looked like cigarettes. Then people started developing larger batteries, larger atomizers to hold more liquid, to give more power, to increase the amount of vape that someone can do. And they've sort of modified and customized over the years. They also contain wicks, and the wick is a key part of this because this is what heats up the fluid. And the wicks contain silica, cotton. They can also contain, the coils contain metals such as chromium, nickel. Again, all things that are carcinogenic on their own. And we don't advise anyone, especially in pulmonary world, we don't say inhaling silica is good. We know silicosis is a lung disease. We know it's an irreversible form of lung damage. We also, as physicians and providers, know that nickel and chromium can be carcinogenic. But these are substances that are being inhaled. Again, another picture of what these devices look like. They can look like cigarettes. They can look like USB drives. They can look like big tanks or mods. But what's scarier is our children are sometimes smarter than us and more savvy than us. And the companies that provide these things are also very savvy. They can also look like this. You can have an attachment to your cell phone that allows you to vape. You can have an inhaler that's actually a vape device, which is scary because it's not often that we say a nicotine inhaler is a good idea. But that's essentially what this is. You're inhaling nicotine through an inhaler. And then there's a company called Vaporware, where you can have attachments in your backpack strings and in your hoodies for vape devices that can be hidden from public view and vaped that way. So again, ways for people to get around adults knowing that they're using these products, or society knowing that they're using these products. So again, scary the way that these things can be hidden from us without knowing. So as providers, one of the things we always worry about is how do we correlate this with smoking cessation? I think we can all agree that smoking traditional cigarettes is not good. None of us here are going to say your patient should return to smoking traditional combustible cigarettes. That's not a good thing. I think that's where we all agree. Where people that laud the use of e-cigarettes for smoking cessation get some of their data is from this Hayek et al. Article in the New Journal of Medicine earlier this year. It was a study done in the UK looking at e-cigarettes versus traditional nicotine replacement therapy. So whether that was lozenges, gummies, or patches, or otherwise. And what's interesting about the UK is they have a National Health Services quit smoking service. This is free for everyone. They also provide multi-sessional behavioral support. So we all know that groups, at Northwell, we're fortunate to have the Center for Tobacco Control, where they're able to help patients in non-pharmacologic ways, which can really be crucial in smoking cessation. They then looked at nicotine replacement versus e-cigarettes, and there was a significant difference. There was an 18% sustained absence at 1 year in the e-cigarette group compared to the nicotine replacement group, which was at about 9.9%, but this was significant. The number needed to treat to get one patient to stop smoking was 12. Again, that's a great number needed to treat. E-cigarettes also provided greater satisfaction and were more helpful to keep people from smoking, but also to prevent some of the side effects that come along with smoking cessation. However, the one big caveat to this is that at the 1 year interval, in those that were no longer smoking, 80% were still using e-cigarettes, whereas only 9% were using traditional nicotine replacement therapy. So really, instead of going from smoking cessation, we've traded one addiction for the other. We've traded an addiction for traditional cigarettes to an addiction for e-cigarettes or vaping. There were also older articles. There was one from 2013 in Australia and New Zealand that didn't show any statistically significant difference. So the data is still coming out. We're still not really sure whether this helps. I think the one thing, and the CDC will touch on this later, is that if your patients have used nicotine to stop smoking, we probably shouldn't be telling them to go back to traditional cigarettes. But in reality, where this stands as a true smoking cessation device, we don't know, and we're still learning. So what's the harm? That's really the impact of this talk, right? Why do we care? Why do we bother with these? If these are better than traditional cigarettes, why not just let everyone do it? And so there's a lot of harm, right? Nicotine is there, and we'll touch on that in a minute. There's the metallic compounds that we talked about. There's cancer-causing chemicals, which are breakdowns of some of these metals. There's the flavoring agents, which, again, there are over 7,500 of these, and we don't know what they do. And they cause damage on the airway. They cause downregulation of host defense. They decrease the effectiveness of your alveoli and gas exchange. They decrease your exhaled nitric oxide. Again, they cause increased cytotoxicity to the lungs. They create increased airway hyperreactivity. So all things that are bad for your lungs functionally. So first I'll touch on the metals. And so again, we talked about the coils, we talked about the joints, the wires. All these things are there, and they're usually made of chromium, nickel, lead, or tin. The hypothesis is that as we heat these coils, some of the metal leaches into the aerosol that we're vaping. And some studies looking at these vapors have shown that there are major increases in the metal in the aerosol sample, right? So we know the e-liquids don't have any metal in them, right? That's good if no one's going to put chromium or nickel in their liquid that you're inhaling. However, when we look at that aerosol after it's been heated through the coils, there are particles of those metals in the aerosol, and so we're now inhaling metals that are carcinogenic into the lungs, and we don't know. And so I think there are soon going to be studies coming out looking at concentrations of metal within the lungs of people that vape. It also, I laugh every time I see this slide. It's 2019, almost 2020, and we still talk about the damage of nicotine. Nicotine is not safe. Yes, it may be better to have someone on nicotine replacement than on traditional cigarettes, but nicotine is bad for the lungs. It's bad for the heart. It's bad for the brain, and it's highly addictive. Nicotine is not good, and this is something as physicians and providers we need to continue to stress and not forget of. The next component is the humectants, or the delivery solvents, the things that make these a liquid that allow people to inhale them. So they come in, the two main humectants are propylene glycol and glycerol, things that you may recognize, things that the FDA has put under a provision of generally recognized as safe, or GRAS, but they're generally recognized as safe for ingestion. The concentrations of these two within the different compounds are varied, so either 50-50 or 70-30 propylene glycol to glycerol. The more propylene glycol, the harsher the hit, and so some people like that. For people that want a smoother hit, they'll get a 50-50 mix. But what's concerning about these is as they get heated up, when they decompose into formaldehyde and acetaldehyde, which again are carcinogenic. And so we're now inhaling a second substance that's probably carcinogenic in our lungs. Then we come to flavorings. There are over 7,500 flavorings at last check, and I'm sure that number keeps going up and up. And if you take a look at a typical Juul label, it'll tell you it has nicotine, it'll tell you it has glycerol and propylene glycol, and then it'll tell you it has flavoring. It doesn't tell you what those flavorings are. It doesn't tell you which ones they are. And so without knowing those, we don't know what effect they can have on the lungs. There are, a lot of flavorings that have been studied. We know cinnamonaldehyde, which is the flavoring that gives the cinnamon flavor, damages cilia in animal models. We know that vanillin, which gives the vanilla flavor, increases your IL-6 and decreases your nitric oxide levels, which are seen in acute lung injury studies. We know that the strawberry flavoring, or dimethylpyrazine, can increase cardiovascular cell death in animal models. And then what's worse is that combinations of these flavorings increase their toxic effects. So combining strawberry and vanilla is worse than having either of those alone. And then we get to diacetyl. Diacetyl has been the flavoring compound that's under the most scrutiny. That's because diacetyl gives a buttery flavor, and it was found about 2 decades ago in popcorn workers. So it's a flavoring that popcorn companies were using. And then manufacturers, people that worked in their plants, came down with a bronchiolitis obliterans, which is an irreversible lung disease. And it turned out it was related to the diacetyl flavoring. So now popcorn manufacturers don't use diacetyl anymore. However, diacetyl is a common flavoring in e-liquids. In the U.S., there have been no reported cases of popcorn lung, but about 3 weeks ago, Canada reported their first case of popcorn lung in someone that was vaping in a 17-year-old. So again, things that we may see. We don't know yet whether these lung damages, are due to amount of ingestion, duration of ingestion, or inhalation, and what may happen the longer people are using these substances. Again, we're only about 10 to 15 years into having these products on the market, and so there's a lot of long-term data we're not going to know about. And then we come to vitamin E acetate. That's what's been in the news over the last month. That's the hot topic. That's the hot button issue. And what vitamin E acetate is, it's a tocopherol. It's an oil that's derived from vitamin E. It's found in a lot of common things: vegetable oils, nuts, seeds, green leafy vegetables. And it too is generally recognized as safe by the FDA. It's available as a dietary supplement, skin treatments. What the FDA did find is that there was a lot of vitamin E acetate in some of the THC oils. There weren't any in the nicotine oils. And I'll tell you why this becomes important in a minute. But it seems that this was first noted or first started being used by a company called Honeycut in California, which provides THC samples. And they started using it towards the end of 2018, which may correlate to why we're seeing this lung injury now. And why they use vitamin E acetate is it's the same sort of sticky consistency that the THC oils are. So it allows people to cut their THC, thereby putting less THC in the product and selling more product, so increasing their bottom line. We know that tocopherols bind to surfactant and impair gas exchange. We know they destabilize the lipoyl hydrophilic balance of surfactant and thereby cause occlusion of the alveoli. And again, really, they don't allow us to have good gas exchange, which is probably why these people are coming in with acute lung injuries. And then you see things like this. This was all over the news a few weeks ago. It's safe as a supplement, it's safe on the skin, but it's harmful inhaled. And so we don't know a lot of this with supposition until the CDC actually did some testing. And what they did, I thought, was very clever. They created an isotope dilution mass spectrometry to analyze specific toxicants. So not just vitamin E, medium chain triglycerides, plant oils, and mineral oils in patients' BAL samples, or bronchoalveolar lavage fluid samples. they took 29 patients from 10 different states, and they checked for all of these things. They checked THC samples, they checked nicotine samples, and they checked for DPPC, which is a phospholipid surfactant, to ensure that they had adequate bronchial sampling. And what they found is that in all 29 patients that had been using these THC liquids, there was high amount of vitamin E acetate. So it's the first time we took a supposed cause of injury in the fluid, and we find it on the patient themselves. So the real thought was that maybe vitamin E acetate is what's causing the lung damage. And fortunately or unfortunately, vitamin E acetate so far has only been found in the black market THC products. This still doesn't explain the subset of patients that have had injuries and state that they've only used nicotine or CBD, or those that stated they've used nothing. And again, whether that's related to people not being comfortable telling us as physicians and providers what they are using or not knowing, we don't know. But the vast majority of cases, again, have been in people that have been using THC-containing fluids. And we do see vitamin E acetate in those fluids and now in the lung BAL samples. The last thing, and again, just to provide a little bit of humor, is sometimes there are things that we don't expect, right? Unintended consequences. And so one of the things is anytime you have a battery-powered device, it's prone to explosion or fire. And so this is from the New England Journal of Medicine, where an e-cigarette blew up in someone's face. And so you see nasal trauma, you see maxillofacial trauma and injury, and this can be quite devastating. It was enough so that someone published a paper looking at both indirect and direct mechanisms of injury, all published data. And these things can explode in your hand, in your face, in your pocket. So a lot of waist and groin injuries, and then secondary consequences. So if it explodes and your house catches on fire, inhaling that smoke's probably also not good. I'm just going to talk about what we've seen here at Northwell a little bit. We've had about 40 cases, and this keeps increasing. I'm told another case has come in to our colleagues at LIJ this week. Our patients have also been predominantly male. Our average age has been 24 and a half, and all but one of our patients did document using THC-based oil. 2 of our patients needed to be intubated, and 3 patients actually had to go on ECMO. Fortunately, none of our patients have died, but again, nationally, we have seen almost 50 deaths, and so this is something that we have to be aware of and on top of. Just to touch through 2 cases really quickly, sort of what we've seen, what type of diseases we've seen. The first one was a 32-year-old female. She came in with fevers, non-productive cough, diarrhea, went to an urgent care center. It looked like this was some sort of viral infection, and she got a Z-Pack. She didn't respond, so she came to the hospital. Didn't have any significant medical, surgical history, no travels, no pets, but she did say that she vaped THC oil weekly for 3 years. Her labs were really unimpressive, except for an ESR that was 111, a CRP that was re-elevated at 26.6, and an ANA that was elevated for an unclear reason. And then her UTOX confirmed she had THC use. Her infectious workup was negative, no HIV, no respiratory viral panel was all negative, and her cultures were negative. And this is just one slice from her CAT scan. She had diffuse bilateral ground glass opacity, something much more anticipated than someone that just had sort of a run-of-the-mill dry cough. So she was admitted. We were able to see her on day 2. She underwent bronchoscopy on day 3. At that point, got the nasal cannula 6 liters, and after the bronchoscopy, given that her infectious workup had been negative so far, we started her on steroids at 1 mg/kg. Again, we don't really have any consensus definition for what steroids to give or not to give, but given that she was pretty hypoxic and not looking so well, we started her on steroids, and fortunately, she started to get better. By day 5, her nasal cannula oxygen requirements were down to 2 liters. By day 7, she was on room air, and her diagnosis actually came back as lipoid pneumonia. In her case, it was an endogenous lipoid pneumonia. So again, maybe this is due to smaller particles than what we saw in castor oil in the past, or maybe this is due to the macrophages killing the dead cells. We don't know, but again, this is what we found in her pathology. And by day 8, she was actually able to be discharged home, and her steroids were cut to 0.5 mg/kg. She was actually able to follow us up in an outpatient about 2 weeks after her hospitalization. Her pulmonary function testing was normal, except for a reduction in her diffusion capacity, which again was probably related to the acute lung injury and the damage to the alveoli that we're seeing. The second case, again, a very young man, a 22-year-old, with fevers, chills, malaise, fatigue, cough, not eating so well, nausea, diarrhea, all those sort of symptoms that we had talked about initially. GI symptoms, respiratory symptoms, and constitutional symptoms. He also had no medical history, no significant surgical history, no travels, no pets, no occupational exposures, but he'd been vaping THC oil daily for 2 years. His labs, he did have a leukocytosis of 19.6, but his ESR and CRP were also very elevated at 113 and 29.4 respectively, and his tox screen also confirmed THC use. His infectious workup was negative, and I'm going to try and see if his CAT scan will play. But what we're really looking at is diffuse curvilinear opacities that you'll see as you come down, but both upper lobe infiltrates and lower lobe, middle and lower lobe infiltrates that you'll see here. The picture will pause for a second, but again, he has multifocal opacities and injuries, much more severe than you would expect for someone without any real significant pulmonary history. This is looking his x-ray from day 1 to day 5, and I don't really have to point out what a difference this was and how significant the bilateral opacities are on day 5. His clinical course was a little bit worse. He was admitted on day 1. We had started to get an idea about these lung injuries at this time, and so we had wanted to do a bronchoscopy on day 1. He refused. Finally, by day 3, he agreed to a bronchoscopy. Between day 3 and day 4 after the bronchoscopy, we started steroids on him. And through this time, his hypoxia was progressing. Again, as you saw on day 5, he had that x-ray with the bilateral infiltrates. He ultimately ended up requiring high flow. He got to as high as 40 liters, 60%. But by day 7, so now 3 days on steroids, he was down to 2 liters nasal cannula. By day 9, he was on room air. His pathology came back as diffuse alveolar damage, again, so some sort of idiopathic lung injury, and he was actually discharged home on room air. He also followed up with us and had a reduction in his diffusion capacity. Actually, 6 weeks after his initial presentation, his CAT scan infiltrates have all resolved. So again, something is happening that's causing lung injury in these patients, and it gets better very quickly with removal of the toxins and probably steroids. This is a look at what his devices were, as well as some of the atomizers. I'm going to try and show you the liquid here, and what you're going to see is a very thick, oily substance that's cascading down this cartridge. That's the substance that's being heated, inhaled into the lungs, and then probably what's happening is it gets heated to such a high temperature that it's going into an aerosol form. When it gets into the lungs, it's getting cooled, and then it's probably getting cooled back into this this element, into this thickness, and that's probably what's being trapped in the lungs and causing some of the lung damage. So the CDC has come out with some statements on what this EVALI lung injury is, what we need to be seeing, and so they've called 2 separate things. They've called confirmed cases and probable cases. A confirmed case is the use of e-cigarettes or dabbing, which is another term for how these products are used, in 90 days before symptom onset, so 3 months. Pulmonary infiltrates on imaging, so either CAT scan or X-ray, and the absence of any pulmonary infection and absence of HIV. If you don't have another positive cause of diagnosis, if you have these infiltrates, if you've used e-cigarettes, you can fall into the category of confirmed case. And again, this does not require bronchoscopy. A probable case is again similar. You've used e-cigarettes within the last 3 months. You've had pulmonary infiltrates on some sort of imaging, and you may have found an infection. So in some of our patients, we've had respiratory viral panels that have been positive with enterovirus or rhinovirus, but we don't think that's the predominant cause of disease. And then no other possible causes, so no cardiac disease, no rheumatologic disease, no malignant processes. That can fall into the bucket of probable case. And this also does not require any invasive intervention, bronchoscopy, or lung biopsy otherwise. The CDC recommends a number of things for us to talk with our patients about and for the community. And some of these are silly, but they're important. This is still an ongoing investigation, so people should refrain from vaping. You know, we think maybe vitamin E is related to this, but that may not be the only problem. If you have symptoms, see a physician. Don't buy black market products. Don't modify your devices. Don't modify your e-liquids. Kids shouldn't vape. Pregnant women shouldn't vape. People who aren't vaping shouldn't start. Again, this seems very common sense, but these are important things to talk to our communities about. And then the caveat being, if you have quit smoking by using an e-cigarette, don't go back to smoking traditional cigarettes. As part of our social history, we should ask people, have they vaped within the last 90 days? If they have, what substances are they using? Can they give us the names of the company, or are they manufacturing the e-liquids themselves? And if you have a case now, you're able to call poison control, and poison control actually um, they'll they'll take the samples and they'll study them and they'll take a look at them. However, again, this is a topic that's evolving in front of our eyes, and it's something that we don't know a lot about. There are a lot of knowledge gaps here. We know about vitamin E, but we don't know if that's the only chemical that's causing lung injury. We haven't linked this to any single product or substance. We think maybe this is related to the THC liquids, but as you saw, there have been over 150 different types of THC products or brands. And we don't know which products, brands, or substances are responsible for this outbreak, and it is an outbreak. We also don't know how to classify those patients that have said they haven't used THC, that they haven't used anything other than nicotine. We also don't know what the long-term outcomes are going to be. We don't know what the nicotine addiction rates are for the kids that are starting this. I think there was one study that said almost 10% of eighth graders, so these are teenagers, that have used an e-cigarette or vaping device in the last 30 days. We don't know what the long-term outcome on pulmonary function is going to be. What we've seen anecdotally so far is that there seems to be a reduction in diffusion capacity, which again makes sense in the context of lung injury. And we hope this will get better, but we don't know. It just hasn't been long enough for us to have follow-up studying. We've noticed a coagulopathy in this patient, and whether the vitamin E acetate impacting the coagulation cascade or there's something else, we don't know. We also don't know what the cancer risk is. The USPSTF has done a lot to get lung cancer screening for our patients that smoke. But how much vaping equates to one pack year? In terms of one Juul cartridge is equal to one pack of cigarettes. Again, that's one Juul cartridge is equal to one pack of cigarettes. We as providers don't know how to quantitate that. And we don't know, we don't know what the long-term cancer risk is going to be from the nicotine products. But we also can't get these qualified yet for lung cancer screening CTs in those patients that are older. We also don't know why this is happening in America, right? Is it that just these THC products here have vitamin E? Why don't we see this outbreak in the rest of the world? Why is it happening now? Is it that vitamin E acetate started being found in 2018 in these products, or is there something else that's happened? And why the severity varies? Why are there some people that do okay and can be managed as an outpatient, and why are there some people that get sick enough to need intubation, ECMO, or some that have even died from this? We're now going to touch on public health policy and advocacy, and I'm going to turn over the screen to Dr. Sagar.
Okay. Thank you, Dr. Canijo. That was fantastic. So I'm going to briefly touch upon policy, and specifically public health policy in regards to vaping and products and e-cigarette products, so all in, right? But before we can talk about where we are right now as of, let's say, 2 weeks ago, I think it's important for us to actually go through a little bit of a timeline of how vaping products have evolved and how policy has followed that pattern of recognition of this product. So first of all, 2003, fun fact, was the first vaping device, was developed in Beijing, China by Golden Dragon Holdings. So you guys can win your How to Be a Millionaire question right there. And it took about 3 years really for the vape devices to get introduced in the US. And at that time, I do want to make a point of this, FDA was not the regulatory body for vape devices. And we'll get into a little bit why that was. But following shortly thereafter, in 2008, WHO actually came out with a very, very clear statement saying that it did not consider vaping or use of vaping products to be a legitimate therapy for smokers trying to quit. And I think this was partly in response to some of the rumor mills, as well as the non-clinical use of vaping devices and recommendations for helping folks for smoking cessation. And then it wasn't until 3 years after the initial introduction of vape devices in 2009 when FDA actually got their hands on a vaping device. They compared 2 different products and found that nicotine was present in both products, and therefore the product label said no nicotine. However, product labels needed to be changed for the manufacturer. But remember, up till this point, the FDA still doesn't have the ability to regulate vaping products. They can regulate the label, they can't regulate the actual device or the product used in the device. And it wasn't until a month later, so June 2009, when the FDA now formally had regulatory power over tobacco industry and its products, including vaping, e-cigarettes, etc. And that was done actually through an executive order from President Obama. Now, FDA, shortly thereafter, because they are allowed to now regulate tobacco and products, came in and said that, okay, we'll follow WHO's lead and caution against vaping due to increased nicotine addiction among young people. That was being cited across various nations, not just the US, so across the board, right? And August 2009, I think, to me, is a landmark time because Suffolk County actually was the first county, essentially, to ban sale of vaping devices to children under the age of 19 years and restrict the use of e-cigarette and vaping devices in public places. And the reason it's important is because at this time, New York State policy and law still had tobacco smoking age to be 18 and above. So Suffolk County said, okay, 19 or below, you are not able to purchase. In September 2009, the Department of Justice in Oregon actually banned sale of vaping devices at some of the travel stores. I believe Pilot Travel Centers and TA Operating are two major travel store chains out in the West Coast, and Oregon actually banned the sale of vaping devices at these stores. And then 2009 closed out with actually one of the major companies called Enjoy discontinuing all flavored, except tobacco flavor and menthol, all flavored products for vaping in order to curb teen vaping. Because by 2009, there was already a significant upswing of middle schoolers and high schoolers' exposure to vaping and thus dependence thereafter. So that brings us to 2009. So there's only 6 years in, right? And then let's get to the next year, and Oregon actually follows or files a lawsuit against a vaping device company called Smoking Everywhere, saying that it was misleading consumers with the safety data of vaping devices and specifically targeted marketing towards minors. 2011, not much progress. There was limited progress in 2012 until April 2013. So now it's 10 years after the first vaping device was invented, that the U.S. Congress really introduced a letter to the FDA to issue regulation over vaping devices to restrict sale, distribution, and marketing of devices to children and young adults. So if you think about it, from 2009, when the FDA first was given regulatory power over tobacco industry, till 2013, there wasn't a significant amount of regulation happening. And then in September 2013, professional societies such as AAFP, AHA, American Public Health Association also called on the administration at the time, which is Obama administration, to allow regulation of vaping devices specifically through the FDA. And again, a lot of 2013 is spent on legislation and campaigning for the purposes of allowing FDA to really regulate vaping products. Okay, so we're not even getting to what regulation we want. We're just purely getting to the idea that FDA can regulate vaping products. We have not cleared that battle yet. And once 2014 came about, basically one of the landmark things that happened in 2014 really was that we had the first case of suspected vaping-associated pneumonia published from West Virginia University, in 2015. 2014, there was a lot of back and forth in the FDA and a lot of calls to action from folks in the Congress, from professional societies to really urge the FDA to finalize their proposed regulations for vaping products, and actually to claim that they have the ability to regulate vaping products. So that is going on. In parallel, now we're starting to see the first case report of suspected vaping-associated pneumonia. So we're going on with that. Now, the Federal Trade Commission gets involved, which I think is very interesting because they start to investigate the vaping companies because, like Dr. Khaneja mentioned, vapeware started becoming more popular, as well as flavors that were specifically recognizable brand names were being marketed, and social media for a lot of these vaping companies is becoming a popular marketing ploy. So the FTC became involved because they was concerned that there was brand name infringement from vaping products or vaping companies. Shortly in parallel, we're having our second case report of vaping-associated nodules that were actually lung and liver that were initially thought to be widespread meth, but resolved after the patient quit vaping. And then in December 2016, the U.S. Surgeon General actually released a report to warn youth and young adults on the risks of vaping. Okay, so we get to 2016, and the reason I'm pausing here is because really 2007 to 2019 we were just waiting, and it felt, when you're reading a lot of this information, it almost felt literally like this emblem, which you see a lot of times when things are just waiting to load, and literally very few things actually happened in policy for vaping and tobacco regulation during this time. Part of the reason is that the federal government is actually involved in multiple lawsuits during that time from tobacco industry, and there was some concern that the FDA did not actually have regulatory rights. However, come 2019, FDA decides they do have the ability, and they are going to restrict the sale of flavored vaping products at convenience stores, gas stations, and pharmacies. And then shortly thereafter, the FDA asks all manufacturers of vaping products to submit applications showing that each of their products actually meets regulations. But they're given 2.5 years to actually submit these reports. So deadline is 2021. And we'll come back to this date in a few slides. By June 2019, a lot of states and cities became a little frustrated with the lack of regulation coming down from the FDA. So they started to regulate themselves, and San Francisco became the first city in the U.S. to ban the sale of vaping products in June 2019. Interestingly enough, San Francisco was also the home base of one of the major vaping product companies, and they had to ban the use of vaping products on their company campus since they were within San Francisco. And earlier this July, the Juul CEO testified under the House subcommittee to explain the company's role specifically in youth nicotine addiction. And I think this is a key portion because at the same time, the FDA recognized that there is a clear campaign to target youth vaping and to increase vaping product use among the youth. So FDA actually launched a $60 million anti-vaping campaign to combat teen vaping. And unfortunately, the same month, we had our first suspected vaping-related death due to lung injury. Now, I think that there were a lot of various states working on their own regulation, and I'm going to go through that a little bit. So Alabama has enacted a law to improve oversight of manufacturing, sale, and marketing of nicotine products, including vaping devices, on their own outside of the FDA and the federal government. And earlier in September, the FDA actually sent a warning letter to Juul Labs, one of the major nicotine vaping product companies, regarding their advertising of nicotine pods as a safer alternative to cigarettes. And I'll go into why this happened and what led to this, but partly it was during the House subcommittee conversation back in July when the CEO very clearly said we are not necessarily advertising nicotine pods as safer alternatives, while the company continued to practice very differently to what they were admitting to. So we've had now San Francisco, we've had Alabama, we've had Suffolk County, New York, and we've had now finally New York State actually bans most flavors except for tobacco and menthol for 90 days. So if you think about September 90 days forward, that pretty much brings us right into the middle of December, end of December this month, when that ban of flavors will be up. And FDA also launched the investigation into the criminal investigation around epidemic of vape-related lung injuries and the involvement of companies and products regarding advertisement and safety data. So Michigan, New York State, Alabama, San Francisco, as well as Massachusetts have all had their own versions of banning either flavored products, all products, some products, or just to certain age groups. But clearly there's a trend in which the states are taking their own restrictions into being enacted, partly because the FDA has been having a very tough time in regulating and really seizing their ability to regulate vaping products. Earlier this month, November 2019, New York State actually finally raised their tobacco purchasing age to 21 from 18. And for those of us who worked really hard on making this happen, for context, what I want to tell you is, I first started working on the New York State raising the tobacco purchasing age about 6-7 years ago, when it was already in full momentum to be pushed forward. So clearly it's taken some time for us to get here. So in summary, so we have 2003 to 2019, right? So 16 years we've been in the evolution of the technology and really the business of electronic cigarettes, because it is a very big industry, and we need to understand that when we think about policy, we need to look at that industry and all of the stakeholders who are involved in this policy making. And to be honest with you, I think the regulation and policy has yet to catch up, partly because evidence of benefits and harms are still being identified, right? So you may ask, well, why am I going through this timeline? Why is this important? The reason it's important is because when we think about policy and advocacy from the physician perspective, we have to think about how long has this been going on and how quickly do we need action to occur, and where are the most likely barriers to making momentum succeed. One of the things in this advocacy for a couple of different issues we'll talk about is the idea that advocacy just doesn't happen at the federal level, it happens at local, state level as well. And sometimes that physician advocacy is actually very effective because states and local municipalities are able to pivot and change policy much quicker than federal policy is able to be changed. So you may be wondering, well, how does this inform advocacy efforts going forward, right? So the way I think about it is, you have a couple of issues. So one is targeting of youth. You have vaping of illicit substances. And then you have like the overall regulation of e-cigs, right? Who is responsible for regulating them? Who should we consider as the monitoring body for these devices and products that are available as consumables on the market? So let's go through this one by one. So targeting of the youth. Dr. Canejo went through a lot of great examples of how companies are building products that would be attractive to the youth. And there's obviously multiple investigations nationally. There are many, 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 many cases against companies such as Juul regarding youth targeting. Now, unfortunately, none of these cases have made a clear conclusion of whether flavored products marketing will be held responsible for increase in teen vaping and subsequent nicotine dependence, even though our empiric data leads us to believe that that's the case. I think nationally, when you think about it, there's no cases that are really holding it up. Also, the other aspect is that the FDA is not very clear on its role to ban flavored cigarette products, right? You may have heard the current administration has kind of flip-flopped their stance on flavored products ban. And the reason I tie flavored products to targeting of youth is because if you remember, there was the FTC investigation in which they are claiming that, companies have been naming their vaping products after brand names. So what are some of the brand names that they have used? They will use things like Chex. They will use things like candy corn and a lot of other normally associated youth products to their vaping products. I don't think I put the picture in here, but there's actually social media. So Instagram has been really, really popular, as well as Twitter, in targeting certain age group of children to ads that promote the use of vaping products. So these are sponsored ads, sponsored accounts that will show up on the feed of anybody under the age of 18, particularly touting flavors that are available, innovative devices that are available, celebrities that are using them, so all of these things. And there's actually a lawsuit right now by a 16-year-old kid who is claiming that through one of those advertisements and sponsorship ads, multiple feeds, he became addicted to nicotine products through e-cigarettes. Well, as far as it comes to where our professional societies stand as far as targeting of youth for these vaping products. So first of all, call to action for more e-cigarette regulation, right? Especially when it comes to youth targeting. Ban of flavored vaping products, including mint and menthol flavors. And raising the national age to buy tobacco and e-cigarettes to 21. So to following suit with multiple states across the nation who have raised their tobacco and e-cigarette purchasing age to 21, national age should be raised as well. Let's talk about vaping of illicit substances. So the regulation policy for illicit substance and vaping has been debated strongly, and it's really come to a head in those states that are moving the needle on legalization of marijuana, because these products are now legally available. However, given the breadth of data that we are receiving, especially regarding harms of products such as THC to be used in high temperatures during vaping, it is becoming more hotly debated because regulations need to be across the board the same for states. We're thinking federal regulation. But, there are a lot of what we call illicit substance or homemade illicit substance mixtures, especially amongst the youth. That is a big concern because there are newer education campaigns, especially from the Surgeon General, that are being implemented to improve the education of both youth as well as teachers, parents, guardians, caretakers around what are the effects of homemade, homegrown illicit substance mixtures and the use of vaping devices and modification of vaping devices for this youth, And it is a very, very strong concern across multitude of professional societies. And I think that there's very limited amount of ability to regulate homemade illicit substances. So funding around education campaigns has been the focus so far. The other concern has been that a lot of chatter online and health policy blogs and health policy world has been about connection between banning all e-cigarette products and potential increase in illicit substance use for vaping devices. Specifically, lawmakers have cited this concern about increased use of illicit substances or at-home creations for vaping devices. There's actually been advocacy groups that have been founded, some of which are industry-backed, such as American Vaping Association. And if you go to this Vice News article, they talk in very, very deep depth about how the conversation around the effects of e-cigarettes on youth or e-cigarettes and the use of THC products versus being a gateway to illicit substance use in the future, or using illicit substances once e-cigarettes are banned. Which brings us to the idea of regulation of e-cigarettes, right? At the end of the day, the question is, who should we as physicians approach to advocate for regulation of e-cigarettes? So in 2009, if you go back, right, a couple of slides back, FDA was first granted control over regulation of tobacco products. At that time, it was not specified to include e-cigarettes and vaping products. 2016, FDA was finalized the regulatory process for these tobacco products, right, including e-cigarettes. Now, that was supposed to be implemented right away, but in 2019, the current administration delayed the start of the regulation process to 2022. So if you remember, I had said that the FDA is finally able to regulate e-cigarettes in the sense that manufacturers have to submit for applications describing what the contents are and to assert that those are the contents in the vaping devices or products, and they have to submit it by 2021. And this is in order to complete the regulation process by 2022. However, one of the e-cigarette companies filed a case in the Court of Appeals a couple of months ago, stating that the FDA did not have the authority to treat e-cigarettes as tobacco products and to subject vaping products to the same set of rules and regulations. And they also used the argument that it was infringing upon their First Amendment right to market vaping products as non-nicotine products. So Court of Appeals decision was unanimously yes, that the FDA does have a right to regulate and that it needs to implement the regulation expeditiously. And the court actually sent in a clear-cut timeline to have this regulation in place and completed by 2020. So that is only a few months away, which has now caused the FDA to speed up their process of getting a lot of this done much sooner than we thought it would be. In addition, even though the court wasn't asked, the judges in this panel actually said indisputably highly addictive and poses health risks, especially to youth, that are not currently well understood. And obviously it's available for anybody to read, but it is a pretty significant setup for future regulation, because all the other losses that are waiting to be closed out, especially in regards to marketing towards youth, a lot of those cases may be able to use this Court of Appeals case as a backdrop to further improve regulation of e-cigarettes and products towards youth, at least, if not in general. So that brings me to our next steps, right? What can we as physicians do? So first thing is, I do encourage you to connect with New York ACP. We at New York ACP is actually This is one of the legislative priorities for 2020 at the local level and the state level regarding regulation of tobacco and e-cigarette products. And if you want further details, you can always click on that link. But remember that a lot of organizations that you all are part of are working on this in some way, shape, or form. I strongly encourage you to email your professional society and say, I am very interested in this. I want to know more. I want to learn how I can help. Because what we need to do is we need to actually create a bridge between organizations. And if you go back to our 16-year timeline, you can see that a scattering of different organizations, different folks, different states have tried to work on it. I think what needs to happen is really we need to come together as one voice and continue to push this forward as an important public health concern for 2020. And that will really be true when we have the bridges between organizations for advocacy connected strongly. And continue to voice concern. As a constituent of different governments, you have every right to write to your legislator and voice concern. Obviously, a lot of the professional societies, including New York ECP, have memos created for you or have certain information available for you that you can recycle, so you don't have to do the legwork. But I think continuing to voice concern is going to be important. And counseling patients is going to be very important, like Dr. Kanijo has mentioned, because we have to team up with patients who are being affected by this or are at risk for this and really voice our concerns on their behalf. Okay, I think we will pause there for questions.
Great. Thank you, Dr. Segar and Dr. Kanijo. That was very informative, very timely, and we really appreciate all the work you have done to help us put this program together. There were several questions come in, and I welcome all attendees on this webinar to please feel free to type in a question on the dialog box and send them in, and I'll be happy to read them to Dr. Kanijo and Dr. Segar. The first one is, do educational programs for adolescents decrease the frequency of vaping in that population?
I think the answer to that is that we don't know. The same way that there were a lot of smoking cessation programs when traditional cigarettes were a big deal. It clearly helped at that time, and I'm hopeful that educational programs towards vaping will be helpful. The kids are clearly starting to understand this and see this. I know myself and some of my colleagues here and some of Dr. Sagar's colleagues have actually started speaking at some of the high schools and middle schools in our communities. But I think really a grassroots effort to get information out to the kids is the best thing. But the truth is, we're not going to know until we have some time. We're going to have to see if the rates of vaping use among children starts to go down, but hopefully it will.
Yeah, I totally agree, Dr. Kanijo. I think that if we think that because of introduction to the idea of vaping through these seminars will somehow increase the students' exposure to the idea of vaping, I think we have to pause and reflect, because they are being exposed through social media and they're being bombarded by it. I think that if they have dependable resources for information in a non-judgmental, non-biased form, that's our best effort to put forward to really curb their desire to even start.
And on the same note, somebody writes in, my 17-year-old vapes and wants to become a doctor. I'm having difficulty counseling him as well as my patients on how to quit. Any advice?
So there are centers out there. I know at Northwell, we're fortunate to have the Center for Tobacco Control, which is really doing a great job. I think the same way with smoking cessation, motivational interviewing, group therapy, depending on each person, it has been very effective, especially for patients that are a little bit older and addicted. For kids, that's a very difficult point and topic. You're obviously going to know your kid best and sort of what they respond to. I think at 17, hopefully, and again, comes with a big hopefully that they're able to sit down and understand some of the logic and reasoning of what you're talking about. I think walking people through what has been seen, some of the lung injury, online, there are lots of pictures of people intubated, people on ECMO, and with the reality that the things that they like to do, so whether it's sports, whether it's going out and moving, can really be impacted. If you get a lung disease that's irreversible, then it means going down the line of potentially needing supplemental oxygen, being limited in your mobility, your activity, and things that no kid is going to want to do. But I think, unfortunately, it's a person by person approach. I'm going to say the one caveat to that is the people that are smoking traditional cigarettes. There's probably still a role for e-cigarettes somewhere in there for people to use nicotine and not illicit products. But I think talking to kids is tough, and the vaping companies are smart. They're very savvy. They've marketed these products the same way tobacco companies marketed cigarettes many years ago. They put people that are very attractive. They put people that are doing fun things. They put celebrities, and they make it look cool. And they make it look like this is what the popular kids do. And it's a real problem. And I think that's part of the reason why Ankit and I talked about having this with Karen in the New York ACP, is that we need to get this information out there, because a lot of people don't want to understand what vaping is. It may be happening in their own houses and not knowing it. But this is a problem that as a medical community, we need to try and figure out what we can do to curb, because we don't need 17-year-olds like your son. We don't need 20-year-olds, 30-year-olds coming to us in 5 years with lung disease from vaping. That's something that we've been moving away from with our traditional cigarettes, and hopefully we'll be able to start to do the same with vaping.
That's so important. That's so true. Thank you so much. It was a very, very thoughtful answer. Another question is, have there been any problems with non-nicotine, non-THC containing recreational flavored vapes?
So again, that's some of the CDC data. There are people that have stated they have not used THC, so they've either used nicotine or CBD, or some people that think they're not inhaling anything. So there are people out there, I think it's about 18%, if I remember correctly, that have stated they have not used a THC containing product. That said, whether they don't know that they're inhaling THC products or they're nervous to admit that to their doctors or providers, I don't know. But I don't know. Most of the lung injury cases are related to THC and black market products, but there are a subset that say they're not. And so I don't know what is causing their lung injury, and I think time will tell.
Time will tell. And I have one final question. So if anybody on this program would like to submit a question, please do so. Is there a standard assessment for nicotine dependence specifically for vaping?
Not that I'm aware of.
Okay. I just had a comment come in. The testimonies and comments from the New York State legislative hearings in November 2019 are inspiring and are accessible online. So that just was a comment from one of our attendees today.
That's great. Thank you.
So I believe that is it for the question and comment period. Dr. Canijo or Dr. Segarra, if you have any last comments for our attendees today, I'm going to wrap it up.
No, I think I've said enough.
Yeah. Continue to advocate on behalf of the patients.
Excellent. It's a great reminder. And I also want to remind everybody that they will be getting an email from Northwell with a very small survey to complete within 3 weeks to get their CME credit and their MOC points. And if you want to share this webinar with any of your colleagues, it will be on the recorded webinars page of the New York Chapter ACP website at nyacp.org. And I will be sending an email to all of you with a PowerPoint or a PDF of the handout. So I'd like to thank everybody today. This is the conclusion of the webinar, and I hope everyone has a happy holiday. Thank you, Dr. Canijo and Dr. Segarra.
Thank you.
All right. Have a great day, everyone.
Thank you.